Hello, everybody. Welcome to our annual general meeting. Really pleased to be introducing this event and our set of speakers on behalf of the Black Country Integrated Care Board and System. On the screen, you'll see the running order of today. So I'm going to talk for the opening few slides. I'm the new chair of the ICB. So really pleased in my first month to be able to look back and look forward and celebrate and look forward to all the brilliant things that we're going to be doing. I'm then going to hand over to Tom Jackson, who's our Chief Finance Officer, who will be going through the ICB accounts and our financial performance. I will then invite Alan Edwards, who's our Audit Committee Chair, one of our senior non-executive members of the board, to introduce Audit Committee confirmations. And then I'm going to pass over to Mark Axel, who's our Chief Executive Officer, who will talk about the year that we have just had. There'll be a lot of information in all of that, but happily, this is a really brilliant new chapter for the NHS, for social care, for our communities. So I'm going to be really pleased to be towards the end of our session presenting a look ahead, making the most of the opportunities. And we will then pass into questions from the public. Thank you. So, a bit of housekeeping. The meeting is recorded. Cameras and microphones are online and automatically tuned off for this meeting. Could we ask that if attendees have any questions, they start their comment with the word question and then pop it into the chat? We have had some questions already submitted by email to us, and they will be answered following all of the presentations. Further questions will be answered live towards the end of this session at my discretion, and all questions will be all questions that have been posted will be added to our website. The presentations and the QAs will be available on our website, and we do have BSL interpreters at the event. And again, allowing the event to run online this year has made sure that we can really plan properly and make sure that all of our diverse needs of our staff communities are met. Our board members will also be at people panels to support wider conversation with community members who'd prefer to meet and speak face to face. So this is only one point in the graph of how we are communicating and sharing. Okay. So I'm sure this comes as no news to us, but integrated care systems, a wonderful new way of bringing together communities with the voluntary and community sector, with the NHS, with local authorities and other key providers, all tilted at improving health and happiness outcomes for our communities in the Black Country. Really pleased to be part of the NHS part of that, which is the Integrated Care Board. We're responsible to meeting the health needs of our over 1.2 million local people. So that involves commissioning, also called buying, but making sure it's in place, planned hospital care, urgent community emergency care, community health services, mental health and learning disability services, our primary medical services, so that includes GPs, but also community services such as pharmacy, optometry and dental, and also some specialised services on behalf of NHS England. So that's us, and that's how we bring our efforts together to make changes in those areas. Thank you. And more importantly, our strategic ambition. So as one of the key organisations in our wider system, our priorities are absolutely to improve outcomes in population health and healthcare, to help the NHS actually as a major anchor institution in our communities to support social and economic development. We are really motivated and driven about improving productivity, value for money, making sure that how we are organised absolutely supports all of that. And of course, bringing all of that together for where we are living, our communities, to support the broader social and economic development. We have 6 priorities. I'm going to go into those in a little bit more detail in the next slide. So before I do, just to talk about the system challenges in which we operate. So COVID-19, absolutely devastating for our communities, for our economy, for our very well-being and happiness. We are still in a process of recovering, just staff groups recovering, our communities recovering, and also playing catch up sometimes with some of the health challenges that resulted from COVID-19. So that still exists for us as a challenge. It still exists in how we're thinking about planning and delivering our care. Which takes me to the word workforce is up on your screens. By no means do I mean to introduce workforce as a challenge. Workforce is absolutely the possibility and potential and the future of sustainability for health outcomes for all our communities. Our workforce are our best asset across public services. What we absolutely know at the moment is we need to do more to support, nurture, encourage and develop our workforce. It's an ongoing programme of work for us. We know we need to get better at that, and we've got some really good proposals for how we do that, working in partnership with our workforce and listening to them, especially as we enter into this winter period. Urgent and emergency care pressures are also listed here as a challenge. Now, obviously, as a standalone challenge, there can be something that we as an ICB and a integrated care system can focus completely on, but urgent and emergency care sits within a wider system of changes, challenges, support across our social care sector, across our communities, across acute hospitals, and also in terms of how people are thinking about their health and well-being, especially this winter. So an ongoing challenge for us to get some of that dynamic right and to make sure as partners across the whole system, we are focusing on that flow. And then finally on this slide, finance and efficiency. You may have picked up through various reports and our press coverage that finance and efficiency continue to be something that we are very energised about. We've got a lot of work to do, but we've also got some amazing groundwork that has been put in place, ideas for how we can get more productive, ideas for how we can balance our budgets as and when we need to, as we recover through some of the challenges that I've outlined on that slide. Thank you. Which takes me to the thing that makes our challenges even more real, which are our communities. So the Black Country, whilst, and I always find it difficult with slides that say challenges when we're talking about our community, these are realities that we have to face in terms of how deprived the geography is and the communities are, and the settlements we receive in order to meet those health and care needs. That is an ongoing challenge for us because our communities do need us to work slightly differently. On the slide, you will see a range of health and well-being concerns where we know as a system, we've got to think really creatively in order to meet some of those needs, but also do things in ways that have simply not been done before. So we are absolutely ambitious about, in some of the public services, we call it closing the gaps, to make sure that those communities that at the moment are not achieving the outcomes that we know they deserve, we know that we need to go back and work slightly differently. And again, that is a challenge for us in how we are delivering our health and care. Thank you. So on to key achievements this year. We have done so much. I'm going to go through maybe 4 or 5 slides now, just picking out a few highlights, and then Mark's going to pick that up in a bit more detail later. So expanded services and care delivery, thinking about primary care. Actually, this is the bedrock, isn't it, of how people experience health, care and wellness. Over 7.25 million patients this year, our primary care team saw. And we've also taken on more and more responsibility as we take on some specialised services from NHS England. We have invested in new facilities, not because we like brand new shiny buildings, but because our communities deserve these. Our buildings were not quite what we would have hoped. They weren't the best settings for how we want to deliver care, and they aren't the best settings for people to achieve confidence in their own delivery of care. So state-of-the-art Midland Met set to open in the next few weeks. Really exciting developments, really in the heart of our communities, and a real beacon for health care, and a brave new future for us in the Black Country. Also, investments in 7-day services and other enhancements to care. We've got huge investments, a £41 million investment in the health of our population. The Edward Street Hospital refurbishment, hopefully again, something that we've been celebrating, each step moving the project closer and closer to the topping out ceremony, which took place on the 19th of June. So here we've got a picture of the blend of staff that it takes to open a facility like this. And again, what an amazing achievement for our older adults and mental health. Dorothy Patterson Hospital, I was privileged to go around and have a look just in my first week. This amazing new facility that replaces the Bloxwich older adults mental health facility. Again, a facility that is loved and treasured, but probably not the right facility for us to really invest in our communities and the recovery and the environments that they deserve. So an amazing new facility opening up. National recognition, not the be all and end all, but it's really great, isn't it? When nationally, regionally, locally, we are recognised for some of the amazing things we're doing. And again, the Black Country probably, I would say, is a bit shy about some of the things that we should be celebrating. So it was great that we're all together achieved national recognition from the Health Service Journal, reflecting again the effectiveness of partnership working, but all 4 of our places, brilliant strengths across the way the partnerships have come together, really in response to those local drivers. Celebrating our impact in specialised care, again, success of the local learning disability and autism programme, highlighted from a visit from Amanda herself, really important to bring individuals who can talk about our achievements, but also help us get better and better through that national influence. We are in an amazing patch, and we have amazing staff, and actually celebrating our diversity, celebrating our inclusion practices, and celebrating the breadth of voices that we have in our system is really important. So again, really honoured this year with the most inclusive ICS of the Year award. And then finally, staff survey score. We unfortunately on the slide there, I don't think there's a benchmark there, but 78 participation rate is phenomenal. It's amazing, and it shows a real engagement of our staff and a real ambition to help us shape what improvement looks like and build on what we've learned from the last year from our staff. So we've achieved the 3rd highest ICB positive score out of 29 ICBs, and the best score of all ICBs in 3 of those people promised domains. That's good, not good enough for us. We want to get better and better. Really pleased to be taking that as a almost starting foundation for this next chapter of us in the ICB. So thank you very much for your time so far. I'm going to pass on to Tom, who's going to take us through a little bit more of the technical insights into our accounts and financial performance.
Thank you, Anu. I'm not so sure how technical we'll get over the next 10 or 15 minutes or so, but we'll see how we get on. As Anu said, my name is Tom Jackson, and I am the Chief Finance Officer of the ICB. As part of my role, I make sure that we keep proper financial records and that we comply with financial reporting requirements, which includes the production of an annual set of accounts and also the delivery of financial performance. The annual accounts and the annual report in all NHS organisations, including ourselves, covers a 12-month period. For this period, that runs from the 1st of April 2023 through to the 31st of March 2024. The production of the annual accounts in the NHS follows a standard format that is given to us by the Department of Health. In general, yeah, we'll do. Thanks, Mark. We're fine as we are at the minute. In general, the accounts are summarised as 4 separate statements that analyse the income received by the ICB, the amount of spend that we have as an ICB, the ICB's assets, who the ICB owes money to, and the movement of cash. The four summary statements are supported by a large series of supporting information. Within the published annual report and annual accounts, the annual accounts start on page 134. For comparative reasons, they will show the previous year's figures as well. As the ICB started on the 1st of July 2022, that comparative period will be for 9 months. You'll be pleased to know I don't intend to go through a page turn of all of the accounts that we have. So how do we get our funding as an NHS organisation? As most people will know, the NHS is funded mainly through national taxation, and of all the government departments, healthcare is allocated significantly more than other areas such as defence or education. Parliament, on an annual basis, votes to allocate funding to the NHS, and the Treasury then pass that funding to the Department of Health and Social Care. They in turn allocate that to NHS England, and last year, being 2023-24, the amount given to NHS England was in the region of £170 billion. NHS England then passed the majority of this funding through to the 42 integrated care boards that cover the population of England, and the money is allocated based on the size of the population, with increases or decreases based on population demographics that drive healthcare need, such as age, sex, deprivation, ethnicity, and a number of other factors. Last year, as part of that 170 billion allocation, the ICB received in the region of £3 billion to cover the healthcare needs of our people. The majority of this funding is given to our local main NHS partners, such as our local hospitals and primary care practices. In addition to this, our NHS partners will also receive money for patients that they treat from outside of the Black Country, or for services that are funded centrally, like specialised services. In total, the NHS in the Black Country spent around £4.3 billion last year. So where has that money gone? I can appreciate that the slide that you have, although it's a pie chart that tries to depict ratios of spend, it's still quite a busy chart. Effectively, the money that we spend on services on a day-to-day basis is called revenue funding, and the money that we spend on mainly physical assets such as building is called capital. Our £3 billion revenue spend for 2023-24 last year equated to, on average, £2,300 for every person in the Black Country. Of that spend, just over half, the majority, is spent to provide services in hospitals, such as accident and emergency, surgery, outpatient appointments. About 10% is spent on mental health services, and 34% roughly is spent outside of hospital. By outside of hospital, we mean community services, primary care, and that would also include prescriptions as well. In terms of the type of expenditure, the majority of our funds flow goes through to fund our amazing Black Country workforce, which we have in the region of about 40,000 staff. I mentioned just that we have two funding streams. One is revenue, which is day-to-day services like people and goods and services, and then we have some expenditure called capital. As Anu pointed out, we've had quite a number of investments last year. In total, we spent £205 million on capital items within the Black Country. This does include some of the high-profile things that we will know about, finishing off the new Middle Met Hospital, Dorothy Patterson unit, as Anu alluded to. But it also includes a lot of vital other services like the replacement of equipment, upgrades to buildings, and other new investments, things like to improve theatre capacity and diagnostic scans. So how did we get on in terms of financial performance? We've colour-coded some of this main performance, where green is we've achieved it, or red is that we haven't. There's quite a number, but they all fall into main categories, really. Every ICB will get a standard set of annual financial standards and targets to meet, but basically they are designed to look to see how we account for, make sure that we don't spend more money than we have, that we use our money wisely, that we continue to increase investment in mental health services, and that we try and pay our suppliers on time. I'm pleased to report that for the ICB in 2023-24, we met all of our main financial performance targets. However, we are also held to account for the financial performance of the wider system, which includes the main providers within our Black Country region. And that has identified some challenges, especially in the delivery of efficiency programmes to get to a break-even financial position. The ICB lived within its expenditure limits for programme spend areas and for its running costs. Our original planned surplus of £5 million was significantly improved upon to a delivery of £18 million, as the ICB found further savings in year to offset what is, by all terms, a significant system deficit. The official revenue position for the system was a £21 million deficit, taking the ICB and provider positions into account. This includes the funding received to cover the costs of the system original planned deficit of £68 million. I mentioned previously that we have a standard to increase our spend in mental health in an above inflationary way. This goes by an acronym called MIS, and that is called the Mental Health Investment Standard. This has been around for a number of years now and applied to CCGs, the forerunner body to ICBs. The ICB invested £220 million in mental health services last year across a number of areas, including inpatient care, children and young people, community services, primary care, and others. Pleased to report that we achieved that investment standard. I do believe that this is an important one. This is a measure, it's not quite as enforced as it used to be a number of years ago, but this is a measure about how we pay our suppliers on time. While many of those suppliers might be large national corporations, there's also quite a few that are local companies that employ local people, and they've got their own cash flow issues. The ICB, there are a number of different measures that generally equate around the value of invoices paid and the number of invoices paid, but I'm pleased to say that we hit our target to pay more than 95% of our suppliers on time, and we continue to work with system partners to improve their performance. I will finish up with a little bit of a forward look financially, but before I do that, just to give a flavour of the sort of things that we get for our money, or that you get as a member of the population. And we mentioned that we saw within primary care just over 7 million people were seen, and they were prescribed 26 million items. Over 500,000 people attended accident and emergency departments, with 362,000 using the NHS 11 service. There was over 1.6 million outpatient appointments, and 157,000 people were moved by ambulance. 167,000 people were treated in hospital as an emergency, and there were over 190,000 planned procedures. That's an operation or an intervention when you go into a hospital. So finally, looking forward, I think it's fair to say that we have some challenges and we have some opportunities. The financial landscape remains incredibly challenging for the ICB, with a sharp focus remaining on financial delivery and the identification of productivity opportunities. For this current financial year that we're in right now, we will continue to receive the second lowest allocation growth of all 42 ICBs in the country. This, taken with the financial impacts of high inflation, the needs of our population, emergency service pressures, and the need to reduce waiting times, means the next couple of years are likely to be very, very challenging for the whole of the Black Country NHS system. However, positively, system partner boards and the ICB have agreed a shared multi-year financial recovery plan to get the system back to financial sustainability, and that is through the delivery of a number of transformation initiatives and a sharp focus on grip and control. In addition, we will have opportunities from the further delegation of services from NHS England and a return to allocation growth that is more in line with national norms. Thank you very much for listening, and I will now hand over to Alan Edwards, who is the chair of our Audit and Governance Committee.
Thank you, Tom. As Tom said, my name's Alan Edwards. I'm the Audit Committee Chair, and I'm here because the Audit Committee has a critical role to play in the governance of the Integrated Care Board. We provide oversight and assurance to the board on the adequacy of the ICB's governance, risk management and internal control processes. We fulfil our role through the deployment of an internal audit team from 360 Assurance, who review these processes on our behalf. At the end of the year, we formally received the Head of Internal Audit opinion on their work in relation to risk management, governance and internal control. I'm pleased to say that they were able to provide an opinion of significant assurance that we operate a generally sound framework in all three areas and that controls are generally being applied consistently. You can see the full report in the annual report. At the end of the year, we are also required to ensure that our report and accounts are reviewed by independent external auditors. They have a critical role to play in providing an unbiased, objective assessment of the ICB's annual report and accounts. This supports effective decision-making by the ICB and ensures transparency and accountability to Parliament, users of the accounts and the wider public. The main output from their work is an independent auditor's report, which is summarised in our annual report and accounts. And you can see a brief summary of it in the slide in front of you. This is reviewed by the Audit Committee prior to formal consideration by the Integrated Care Board itself. This review involves the committee discussing the detailed findings from their investigation. We use Grant Thornton to undertake this work. They are the leading provider of public sector auditors in the UK with a highly experienced team. So I'm pleased to say that the external auditor was able to provide a clean audit opinion that is summarised in this slide. It shows that in their view, the financial statements give a true and fair view of the financial position of the ICB and that they have been properly prepared in accordance with international accounting standards and that they are being prepared in accordance with the requirements of UK legislation. Based on the work of our external auditors and our internal auditors, plus the Audit Committee's own analysis and assessment, it was able to recommend approval of the 23-24 annual report and accounts to the board on the 27th of June 2024. I'll now hand over to Mark Axel, our Chief Executive, who's going to pick out highlights of the year.
Thank you, Alan. Thank you, Tom. Really clearly explained. Thank you so much. I've got about 10 or 15, maybe more slides to take you through. And as I've looked at these slides, it's absolutely impossible to do credit to the work that is going on, both in the ICB and across the system, because we would be here till 11 o'clock at night. So colleagues that don't know me, my name's Mark Axel, I'm the Chief Exec, and I'm here to tell you about the things that we have achieved in our first full year, actually, 23-24. We had a partial year before that. And it themes quite nicely, actually, so I'm going to talk to you about performance, partners, population health, primary care, people and communities, and people in terms of our workforce. There's lots of P's in there for some reason. And I think it's important to recognise that this year was a challenging year in many different ways, continued recovery from COVID, but also it was a year that very challenged through industrial action in terms of being able to deliver services. So the achievements I'm about to tell you about are testimony and credit to board colleagues in this room and executive colleagues, which people can't see online, but they're all in the room. So thank you to board colleagues, but also to our partners across the system, because we work best when we work in partnership. And the leadership, all of our partners at all levels across the system have delivered the results I'm about to take you through. Next slide, please. So we can't take you through all of the constitutional standards because there's many of them. We publish every month in our board papers our performance report that goes through all of the detail of that, and we will publish these slides on the internet when we've completed this AGM, so you can go through them in more detail. But the NHS has a constitution that has a certain set of standards within it, and quite rightly, as we come out of COVID, the decision was made that actually we shouldn't drop that bar. So many of the targets you'll see here are targets that were set pre-COVID, but quite rightly, the expectation is that we get back to the standards we were delivering before COVID in terms of our key constitutional standards. And in many aspects of that, we do lead the region, and I'll talk more about that in a moment. But if we start with mental health, a really fantastic story. Thank you to our partners, particularly Black Country Healthcare, in terms of delivering improving access to psychological therapies, both in terms of 6 and 18 weeks, exceeded the target, and actually through those 2 years maintained that. And we know historically that access to IAPT has been a challenge for the Black Country, so really good to see that improvement. And similarly, in terms of early intervention in psychosis, well above the 60% target that we need to be. Next slide, please. In terms of other areas of performance, we've talked, I think, over the last few AGMs about the elective recovery, about urgent care recovery on the back of COVID. And you'll see on the slides that we've got today, and these have been refreshed and linked to our annual report, that in many areas, whilst we may not be achieving the constitutional standards, we're continuing to lead the way in terms of the performance that we deliver in the region. So, for example, if we look at A&E 4-hour waits, that figure is the March figure, the cumulative figure for the whole of the year. But as we left 23-24, as a system, we were above 76%, which was the NHS England target. So that's the average for the year. But as we left 23-24 and went into 24-25, we were actually moving up above 76% and actually identified as one of the top 3 integrated care boards in the region for that. A real success story in terms of cancer 62-day wait and also 31-day, where again, we've seen significant improvements across our providers to make sure that we are moving towards the national target. And on faster diagnosis standards, some really fantastic work. Some of our trusts are in the top 3, top 4 nationally or regionally. And of course, an ambulance turnaround waits with our partners at WMAS, the best ambulance turnaround responses, call time, again, in the region. But I think it's really important when we talk about performance that we're never complacent, because we know we can be better and we want to be better in the way we deliver services. And we'll talk later on about what some of those developments are. So to put a bit of more detail to it, as I've said, 76% was where we ended up as we exited the year, above 76%, well in excess of the national average and the Midlands average. And we exceeded that target and have continued to do so. Walsall Healthcare in particular, one of our partners, one of the best nationally in terms of this work, and has identified for national best practice, and indeed has been asked to help other organisations across the system. Reducing long waits for operations, elective treatment as we call it. We cleared all 104-week waiters as we start to move down and reduce those waiting lists. We've gone through 78 weeks. The next big target that's about to come upon us is 65 weeks. And all parts of the system are now working hard to reduce down the number of patients that we have waiting above 65 weeks for that September 2024 deadline. Then we move into 52 weeks, and we can keep going right through the next few years as we continue to reduce elective activity. And I've talked a little bit about cancer waiting times and faster cancer diagnoses. It's really important that as an ICS, but as an ICB, that our partners and the way we work is representative of the communities that we serve. We know that actually our partnerships are the heartbeat of how we deliver great care. And we know that people in the Black Country absolutely are proud of their neighbourhoods and should be rightly proud of them. Recognise their 4 places, as we call them. So for that's Wolverhampton, Sandwell, Walsall and Dudley. And where needed, that we aim to make sure that, if need be, that they can access care in a Black Country footprint for a population of 1.3 million. So our place-based partnerships, and Anu's already touched on one of our place-based partnerships, are really at the heart of that. That's where we work closely with local governments, with housing partners, with primary care, with our acute trust colleagues, our mental health and LD colleagues, social care, to bring together resources and start to plan. And this was always going to be something that we built over time. Partnership doesn't happen overnight. It won't happen in a year. It's about building trust, and it's about starting to make shared decisions that benefit the population that we serve. But equally as important is that we have collaboratives working together where we think we can do things in a better way for our population, be it about access, quality of care, or actually innovating in the way we do things. So really delighted that we've got 3 collaboratives that work at a Black Country level. The Black Country Provider Collaborative, our 4 acute and community trusts, working together on some of the things I've just described to you. So for example, how do we make sure that we get their operations as quickly as we possibly can? So using theatre capacity across the Black Country to make sure that we're offering treatment as quickly as we possibly can. But thinking about innovations in clinical pathways, looking at best practice from outside of the region and bringing it to the Black Country. And the one thing I'll say about the Provider Collaborative is that the clinical events you go to, clinical services and clinical innovation is absolutely at the heart of it. Our Primary Care Collaborative, a really important element of what we're going to do next, and we'll talk more about in a bit. And that is our GPs, but also our new partners around dental, pharmacy and optometry. And then our mental health, learning disability and autism lead provider in Black Country Healthcare that led the way in some of that joint working and taking on that collaborative role. And I've shared some of the results with you already that we're seeing improvements on. So partnership is absolutely at the heart of what we do. Because our partnerships will enable us to be able to tackle not only delivering services, but also to tackle health inequalities. We know that the Black Country is one of the most deprived areas in the country, but we've made a really great start in 23-24 in terms of the things that we've looked at and addressed. So we did an evaluation, it's called the Health Inequalities Improvement Programme, and we've really taken some of that learning forward, including for the first time starting to consider how we invest in services based on health inequalities as well as population levels, to recognise that to level up and start to move forward on health inequalities, that we need to invest differently in different areas of the system. Some of our work has rightly been recognised as award-winning, and in particular, our population outcomes framework. Historically, the NHS has always measured its services in terms of number of people on the waiting list, number of people waiting 4 hours, some of the measures I've just taken you through. This takes us to a new space in terms of looking at housing, employment, activity, social mobilisation. And I'm really pleased that our place-based partners have now signed off that outcomes framework so we can use it to drive the improvements that we want to make. We've also, and I just come a few weeks ago from an absolutely fantastic event, started to think about our different partners. And what we know, and the Health Foundation did a piece of work, is that if your housing accommodation is poor, you are likely to have somewhere around about 10% worse health outcomes than somebody who lives in good quality housing accommodation. So we've been really driving forward and set up the first ever Black Country Health and Housing Forum. This has been a significant first and actually has been looked at nationally in terms of how are we starting to think about the links that we create. And that's two-way. That's about how do we support people in housing accommodation to keep well, live independent lives, make sure that the accommodation they are in is healthy for them. And we've got some really fantastic work going on, including our asthma teams, looking at how do you kind of create a kite mark for asthma healthy housing going forward. But also the other way about thinking, how do we support tenants in housing to actually gain employment? And I know in Walsall, for example, a really strong partnership between the Healthcare Trust and Walsall Housing Group has driven that agenda along. But we can't stop there, and advancing health inequalities and addressing them is part of what needs to be part of our DNA, the way we do business. It's new to us. It's new to us as part of an integrated care board and as a system, but we need to drive further. And the core 20+5 model, which is a national model that kind of looks at the 20% of the national population, the 7 domains, has a local element to it in terms of the priorities we want to take forward, will absolutely underpin that. But making sure that through all we do, through be it how we work together, cultural development programme, how we assess and make decisions, so thinking about health equity in all we do, in our policies, taking things and scaling them up, the Beyond Pockets programme. I heard somebody say the other week that the NHS has more pilots than British Airways. It's really important that we really start to take forward those pilots and scale them up, but also continue to work with our partners around tobacco treatment, prevention, and really pleasing that as we start to move into the new year and a new government, prevention is really at the forefront of that thinking. One of the challenges we absolutely recognise is accessing primary care. And as a board, we are really clear that addressing that issue is one of the things that will drive significant improvement for the population that we serve. In the year, we've offered, I think, more ways than ever for primary care to be accessed. That includes a digital first approach around looking at our practice websites. Are they clear that so when somebody uses them, they can actually access the services they need and be signposted appropriately? Thinking about online and video consultation, starting to think about what does future general practice look like? Technology evolves very quickly. So what does modern general practice really look like going forward? And really starting to think about, at the heart of this, like all services, is our fantastic workforce. So how do we grow and invest and grow our workforce? And you will see on the slide that our workforce has grown by 6% during that time period, which is just fantastic. And thinking about how we work at a slightly greater scale than maybe just a single primary care practice, how we work with primary care networks, or even how we do training across the Black Country. We've set up a Black Country training hub to make sure we're training all of our primary care partners and raising standards and driving skills and hopefully retention in what we do. Next slide, please. We've also, as I've said, had new partners join us. So community pharmacists will be an absolutely key part of what we've done. We've worked really close with them during those first 12 months, thinking about the role that they can play in consultation, pharmacy first, in terms of the population being able to access services more rapidly, thinking about what services that pharmacists could offer in the future. And as I've said, the Black Country Primary Care Collaborative, which will really drive that kind of single voice from neighbourhood to place to Black Country in terms of making sure we learn and share best practice. And I'm really delighted to say the work's delivering benefits already. So the Black Country's already been identified nationally in terms of the lowest level of leavers in the primary care workforce, in terms of retention of the workforce, and in terms of recruitment of the expanded roles that you will see when you go into a primary care practice, what we call ARRS roles. And they can range for everything from care coordinators, physio, all of the roles that sit alongside GPs. So workforce, as I said, is at the heart of this. So it's great to see that the decisions we're making are already having an impact. To sit around that, we've got our One Health and Care record. That means that you don't have to tell your story more than once. That is the aim. We've got community services, acute, mental health, primary care and social care, all sharing information through that, thanks to our digital team in driving that agenda. 8,000 users and 130,000 records, Mike, is that correct? Or was it 1.3? Sorry? 130,000 records accessed. So really starting to be used now in how we make up joined up clinical services. And we've started to think about what our responsibilities are around commissioning pharmacy, dental and GP services. Because for many of you in your neighbourhoods, they will be part of your communities, and how we bring them together and commission them and offer alternative service provision is really, really important. Next slide, please. One of the reasons I do this job, and one of the reasons that we are here, is to make sure that everything we do is co-produced with our people and communities. I absolutely see as Chief Executive that accountability piece as an organisation to the communities that we serve. But we have to recognise that one size doesn't fit all, that the healthcare needs of one part of the Black Country will be very different to the healthcare needs of another. And that can be no more vividly described that if you look at some of the health outcomes just between Walsall and Dudley, they are very, very different. Yet if you drive down the Black Country route, you probably don't experience that. So we recognise that one size doesn't fit all, and that in our conversations, we start with the people in the communities that matter. It's not always us. We know that for some communities or even for some issues, that actually trusted voices are key in what we do, that actually people will trust somebody local to their community more in telling us what they think. So it really is at the heart of what we do. And our people panels continue on a regular basis. So there's been more this week. There'll be more to come. And I really, really would encourage members of the population to really come forward and be part of those. We're just in the process of concluding a conversation around the future of primary care. So thank you to colleagues that have, and the population that have taken part in that. And as we go out into the new year, the NHS 10-year plan that's been talked about, we will definitely want to get into a conversation about what that looks like for the Black Country. But we recognise that not all the time it goes as our population would expect. And it's really, really, really important that patient experience is the heart of everything we do. So our Time to Talk team are part of the Integrated Care Board, part of our team, and their role is to make sure that complaints or concerns are addressed in a timely manner and addressed in a way that gives the person raising the concern the appropriate answer that they need. Next slide, please. And of course, we communicate in so many different ways because we recognise that people access their information in so many different ways. So just on this screen now, you'll see all of the ways that we make sure that our information is accessible to patients, staff and the public, health promotion and sharing good news, listening to the views and experiences. In the last 12 months, Time to Talk have handled 3,484 contacts, 180 comments, and our online patient and online forums over 2,700 members. And that's really part of that drive for a two-way conversation. And that can be positive comments about services experienced, but also people feeling able to raise concerns when they believe that the service is not as it should be. And at the heart of this, every month at board, we have either in person or a video, the views brought straight to us from citizens across the Black Country. It's really at the heart of what we do. It challenges us as an organisation to think differently about the services that we provide. And as I've said, our 10-year plan will definitely get into that space. We'll want your views about what the 10-year plan for the NHS looks like. And our people panels are absolutely at the heart of that. Improving quality of services, really important. And we've got a fantastic team that lead on this, that actually advises both and works with partners in the Black Country, but also advises regionally and nationally. And there's nothing greater than to see the team implement a quality initiative and then be asked to go and share that with other neighbouring systems or across the country. And some examples are on the screen of that. So it's really important we get that external perspective in terms of are the arrangements robust? And it was really good to get that audit done in terms of primary care arrangements. We've taken on a whole new set of delegations in the year around specialised commissioning, and the ICB led on the arrangements for the region in terms of setting that up. Individual placement quality reviewing officers. So this was learning from a case we had in the Black Country. We recognise that for some of our care, we do have to put people into specialist placements. The nature of those specialist placements sometimes mean they can be in different parts of the country. And some learning from a particular case that we had was that we need to do more to make sure that we're assessing the quality of those placements. So we actually led the way in terms of implementing the new roles. They're having a real significant impact in terms of how they work with those placements, how we assure ourselves on the quality. And again, we've been asked to lead and advise nationally and regionally on that. And at the heart of this is the new patient safety incident response framework, which is all about learning with our partners and make sure that we learn and share and take improvements forward. We can't do any of this without our ICB people. Fantastic people. And whilst we're delivering services, it's really important that we look after them. Their role is far-reaching across the organisation and across the system. And quite rightly, what we've done is far-reaching as well. So it's really important they have networks that come together, and we have our free network, which is absolutely representative of our BAME community. And the free network is a fantastic voice in terms of sharing those experiences, what it's like to work in our organisation, and more latterly and more recently was significant in terms of recognising how communities were feeling through the recent riots, because our staff are our communities as well. We've already talked about the NHS staff survey. It's a national process. We did really well last year, 79%, I think, uptake. As Annie was rightly said, and as I've always said in my chief exec career, we don't stop there. Because as soon as you start not thinking about the culture of the organisation, the support you give to staff, it starts to change very quickly. So whilst we had good results, we're about to go into this year's staff survey, and absolutely when we get the feedback, we will continue to work on it. And because we're a relatively new organisation, it's important that we think about our OD approach, our strategy, our culture, our priorities, and do that with our partners. And when we think about things like leadership, team development, behavioural frameworks, all of the things that we know will continue to make a thriving system and continue to make a thriving organisation. Next slide. But we have to make sure that we continue to think about the future. What roles will we need in the future? How do we make sure that we recruit and retain the very best talent we can across the Black Country, and that the Black Country health and care system, including the ICB, is one that people want to come and work for, no matter what your background or which community you come from. So the people plan, the Black Country version of it, is really, really important in terms of thinking about not only how we recruit and retain, how we think about new ways of working for the future. Artificial intelligence is something that's coming over the hill very, very quickly. Will we in 10 years' time need to be thinking about having more digital expertise in the organisation? And we work really, really closely with our partners like the University of Wolverhampton, our training partners. And alongside that, our workforce plan, and really importantly, our EDI strategy. And all of us as leaders across the Black Country have signed up to support our EDI strategy and have taken leadership pledges. And next week is Inclusivity Week, where all of us as leaders will be talking about how important this is to us and the themes that underpin it. So a huge amount I've covered there. I can't do justice to everything that everybody's done in the year. It's our first year, some really significant steps. So just thank you to partners and colleagues for all they've achieved, but we don't stop there. So I'm going to hand back to Anu, our chair, to take us through the look ahead. Thank you.
Mark, thank you. I mean, how to follow that list? And as Mark, you've said, that's a fraction of the change we've delivered in partnership for our communities. I guess what I want to do is move us quite quickly to this next section and then on to questions, because the bit I want to talk about now is what next for us. And obviously what next must be built on what we've already established. So as Mark says, kind of year 2 for us, such strong foundations. The slide that it's on the screen now is incredibly busy. I don't intend anybody to try and make sense of that. But what we have done is we have tried to pull together the things we know we're good at, the things we know that we need to do better, the insights we've got from our communities, making sense of the passions and excitement of our staff, our partners, our organisations. Add to that national policy, national drivers, and we have a sense of direction going forward. When the slides come out, and I think you'll see it in the annual report, these really are our kind of 6 priorities. We had 5. We've introduced a 6th, which I'll come on to in a moment, for really important reasons. But our joint forward plan does do what I think any good system needs to focus on, which is make sense of 100 moving parts. So we need to pull together all of those insights into something that is coherent, will make a difference, and is affordable. So the joint forward plan is a document that we use. It's our compass setting. It's the compass setting for all of our partner organisations, but we know we can't rest on our laurels. So we have just had a refresh of that forward plan, and some of us love plans, and some of us love to see things happening differently on the ground. I think this really is the best of both. It picks up where we are going, what we need to do, building on some incredibly exciting developments that we've already got in the bag. And we're about to refresh the plan. There are a couple of key drivers for that. Many of the things Mark's already alluded to, Tom alluded to it as well. We have to deliver affordable care. So we have to make sense of our finances. We have to, taking some of the national directives coming our way, we have to take a long, hard look at how we are attributing spend and tilt it at the changes we really need to drive for our communities. So a very exciting time for us. We know we need to get better at doing some stuff, but we also know we need to get smarter at doing some stuff. So sorry, just leave that slide on. I'm just going to talk a little bit more about the invisible writing on this slide. So priority 1, improving access and quality of our services. Again, we've talked about it this evening. Our core function is to provide that quality healthcare. We absolutely know people do not have the access they need at the moment. We need to get smarter at that. We need to think about different kinds of access. We need to listen more, and we need to support our workforce and our services in order to improve quality and improve accessibility. Priority 2 is care closer to home. Absolutely. Why on earth would we ask people to get better, to manage their wellness, to develop their next stage in their recovery in places that are far away from where they live, not really connected to how they're living their lives? We know as an NHS and a set of partners, we need to bring care closer to home, support general practice, support people to be well in communities where they feel stronger. Priority 3, preventing ill health and tackling health inequalities. A bit later on, I'm going to talk about the Darcy review, but imagine the joy finally to hear across a government intervention, an important document on the Darcy review published last week, a complete embracing of prevention, pushing interventions upstream, as they call it. But for me, it's about helping people live according to their strengths, according to what matters to them, and supported to live the best lives they can. And we can absolutely do more around that. And perhaps one of the things we need to reflect on now in this next period is actually how can we start to shift some of the activity we're investing in into prevention, into supporting people in a strengths-based and person-centered way. Giving people the best start in life. Could there be a more fundamental priority for any health and care system? But priority for giving people the best start in life. We know absolutely that those early years, those continuing years, setting those habits, supporting wellness in a way where we absolutely know we have to intervene in a child or young person's life. We have to get that right, and we're continuing with our partners to improve access and outcomes for our young people. Mark very passionately, I thought, talked about workforce as a theme through almost all of his slides. Absolutely. Priority 5 for us is the best place to work. Now, we know our 60,000 colleagues that are toiling away have not always been doing it under the best of conditions, not always been doing it with the support they need. We absolutely need to keep this as a really live priority, helping our workforce and our wider teams across the Black Country, who are all tilted at helping people to thrive, be well and be happy, to actually be well, happy and thrive themselves. And priority 6 is fit for the future. So this is our newer priority that we've introduced, because what we don't ever want to do is sit on our laurels and think this is the way ahead for us. Let's get our head down and motor on it. Whilst we were delivering our strategy, we realised actually, in terms of the financial challenge, in terms of the productivity challenge, we need to reharness some of the existing good work around productivity, but also really get creative around how we can introduce different ways of working, digital, engaging people's passion and creativity in new and different ways. So fit for the future is a really important strand of our strategy. Thanks, Bonnie. So the next 2 slides, I think, next slide is about a really important part of how we function, which is our integrated care partnership. Again, Mark and colleagues have already alluded to this. We do not deliver health in any way on our own in the NHS. We work humbly in partnership with our communities, with our families, but also with the rest of the organisations, bodies and agencies that are in a similar space to us. We know we cannot achieve wellness in any way without looking at where people live, how they live, their ambitions, their happiness and their financial success. So the integrated care partnership is a brilliant way of bringing lots of those voices and those statutory and non-statutory partners together. We know we've been on a development journey here in the Black Country. We know that what we've built is absolutely right for where we've come from. We didn't really have these structures, but we absolutely know that the next stage of our integrated care partnership is going to do some brilliant things about really landing some of those challenges Mark shared around housing, well-being, the economy, really bringing that together in a really powerful way for our communities. Next 2 slides are on primary care transformation. Again, really important to repeat this. Primary care, getting things right at community level, getting things right for general practice has got to be the bedrock of a sustainable health and care system. So primary care transformation, we absolutely know that the volume of demand is not meeting some of the interventions we have put in place around primary care. So on the next slide, you'll see we have been really investing in primary care transformation. And it's already paying some really important dividends. We are getting some really supportive support nationally, regionally. Our transformation is being recognised, as is the social movement we are growing around doing things differently in partnership with general practice, with the new roles that are coming in, and essentially with communities themselves in how they engage with that primary prevention. But really exciting space and an important space. So I just wanted to end with a few final thoughts. I was absolutely thrilled to read the Darcy report. And I think the timing actually couldn't be better. We've got so much happening in the Black Country that is new, challenging, different, things we've learned from the ways we've been developing and transforming before. it is absolutely right for us to heed the call in the Darcy report and absolutely move our activity, our interventions and our support into that prevention space, into that understanding our communities space, and also being bold about doing things differently, and embracing almost this once in a generation challenge with the integrated care systems coming together, a government that is very focused on improvement, NHS and social care that is in the spotlight for many of the good reasons now. This is our opportunities to lift and develop and walk into a very positive 10-year strategy that will be published in the early next year, along with our refresh of the joint forward view. So I just wanted to end on thanking all the people on the call, but the broader partners, communities, amazing 60,000 staff we've got who have made it happen for our communities in the last year. So again, as Mark said, a fraction of the activity and the change has been referenced today. We couldn't get it all in our annual plan as well. But great thanks for everyone who's made that happen. And also thanks to Jonathan, whose term ended. And I've got the great privilege now of chairing this amazing system and this amazing organisation, but wants to take this opportunity to really thank Jonathan for his amazing and inspirational leadership. I'm going to end there and take questions. So we do have questions that have been addressed to us, which I will read out. And then I will invite my colleagues to answer those questions. So the first question we have is, what processes are in place to address bullying behaviour faced by patients when PALS do not take any actions? And I'm going to invite Laura, I think, to come up and just in a few words, please give us your take, and we will publish obviously the questions on the answers.
Hello, good evening everybody. My name's Laura Broster. I'm Director of Communications and Involvement here at the ICB. I'm responsible for the ICB's complaint service, which is called Time to Talk. Obviously, we wouldn't want any patients to experience bullying behaviour in any situation. But the question asks about PALS and a lack of action by a PALS team. Clearly, all of our providers have a PALS team, which is there to support local resolution where possible. And my message to anybody who's written this question, which has been received anonymously, would be that if you are experiencing trouble in accessing the PALS team, then you're very welcome to contact us here in the Time to Talk team. Details are being posted in the chat as we speak. And all complaints received here at the ICB are investigated, either by us or by the providers, and full responses given. So if anybody is watching this who's put the question in, then please do get in touch and we will respond back with any queries that you've got. Thank you.
Laura, thank you very much. So second question is from Brian Albert from Sandwell in West Birmingham Pensioners Convention. And he writes, several of our members have ongoing concerns about being unable to see the same general practice doctor, often having their long-term health issues reviewed by 3 or more different doctors within the same general practice. This lack of consistency, particularly where patients have quite complex and long-term health conditions, is causing some of our members real concern. The question is, what is the policy of the Black Country Integrated Care Board about the importance of general practice within the Black Country, ensuring that where patients have complex and long-term health conditions, they are allocated a specific general practice doctor? And I'm going to invite Saab Bassi, our Primary Care Director, to come and address that question.
Thank you, Chair. So we know continuity is at the heart of general practice. And we also know that people who receive continuity have better health outcomes and higher satisfaction rates. We know workload levels are increasing, demand is increasing, and we've had a lot of challenges around workforce shortages. However, we've developed a primary care transformation strategy that will focus on planned, unplanned and preventative care. And our approach really is to focus on planned and preventative care as the best way of actually tackling unplanned and same-day demand in primary care. We know the 6 areas that drive, the 6 disease areas that drive demand in primary care, and we'll be developing care pathways, particularly for those people with complex long-term conditions. National policy, i.e. Modern general practice, means we'll be introducing triage. And this means that we get the right patient to the right professional at the right time, and that's going to be critical. We mentioned workforce challenges. However, Black Country is bucking the trend in terms of the increased number. The most number of trained GPs are increasing, and also we've been the most successful ICB across the whole of the Midlands region in recruiting additional roles. And finally, the development of integrated neighbourhood teams providing joined up holistic care will actually give the best benefit to patients who require continuity, i.e. those with long-term conditions. I could talk about this for an hour, and we will publish a more detailed response, but we'll also give you a link to our strategy document.
Thank you very much, Sam. The last question we have is also from Brian Albert from the Sandwell and West Birmingham Pensioners Convention. So the question reads, we have serious concerns about the role of physician associates as part of extended health teams across health and primary care services in the Black Country. The BMA have already raised concerns nationally about how physician associates are used in relation to the length of training which they've undergone and their limited capabilities vis-à-vis qualified doctors. What is the role then of physician associates across health and primary care services in the Black Country, particularly concerning seeing unselected and undifferentiated patients, diagnosing and initiating treatments? How are physician associates trained, supervised and deemed competent when working in health and primary care services across the Black Country? We believe that the Black Country Integrated Care Board should lead by example on this issue, with physician associates' duties being strictly limited to professional competence. So I'm going to invite our Chief Medical Officer, Anantha Dave, to address this question.
Good evening, everyone. I'm Anantha Dave, Chief Medical Officer. So in response to the question, physician associates are working currently in the Black Country across our primary care and community and hospital services. We do not currently have any physician associates working within our mental health care services. In terms of how they are appointed or so I'll start with how they are appointed and the qualifications that they need to have. So the physician associates must be registered on the Faculty of Physician Associates Managed Voluntary Register. And from December of this year, they need to be also regulated. They will be regulated by the General Medical Council. In addition to their undergraduate and postgraduate qualifications, they must have passed the National Physician Associate Registration Assessment, or PARA. So in terms of appointment and how they work or where they work, physician associates in the Black Country work within teams. So they do not work in isolation. They work in multidisciplinary teams. They do not see what we call undifferentiated patients, which means they do not see patients who have not already been seen by senior clinicians, and they do not make independent decisions. They are closely supervised at all points of their work throughout all the settings that they work in. They receive considerable support apart from that in terms of pastoral support, and they are always accompanied by a colleague so that they are not working independently with patients. And we also ensure that throughout their career, when they are employed with us, they have what we call continued professional development, so that they have to maintain a portfolio of their training activities and continuing development in order to demonstrate that they are fit to work. And within the Black Country, we work closely as a group of clinical leaders across hospitals and primary care to ensure that all physician associates follow this policy. They do not prescribe and they do not make any decisions around diagnosis. Thank you.
Anantha, thank you. I'm going to invite Mark now to address the online questions. I believe we have a question that's come in live.
Yeah, thank you. So we've had one question online, and it's from an anonymous question asker, and it asks about the media coverage on BBC Midlands today in August around the serious concerns at Black Country Healthcare, and it asks who is responsible for this. So to answer the question directly, I think in the slides that we've talked about, we have many roles as an ICB, be it quality, be it workforce, be it culture. And one of those is about assuring ourselves that our providers, their boards, are taking all the actions that they need to when concerns are raised. That's across all of our organisations, and we do it in conjunction with NHS England. In this particular example, we've absolutely heard the concerns that have been raised, and we've conducted and are conducting an investigatory visit to the organisation in conjunction with NHS England to speak to colleagues in the organisation, to do site visits, to get and hear those concerns. And then once we've concluded that, we will work very closely with the Trust in terms of what action needs to be taken to address those concerns. So thank you for the question. It's something that's the foremost of our mind. Quality is absolutely at the front of what we do. And that's why we have the fantastic team we do, to make sure that we challenge and work with our organisations. And absolutely, we've heard the concerns and we'll take them forward in the way I've just described. Thank you.
Thank you, Mark. I don't believe we have any further questions. So it's my privilege then to close the AGM. Before I do, I just wanted to thank our fabulous communications team, our technical support. It has been no mean feat to pull this out of the bag. And as usual, it takes a lot of talent, a lot of dedication, and a lot of coordination to pull an event off of this magnitude. So thank you to our communications team, and thank you to everybody, all our partners who've attended online. Really amazing to have your support at this kind of event, but also throughout the year. Thank you very much.